I want to welcome everyone to today's webinar, Sorting Out Significant Procedures. And Christy Pollard is a senior consultant with Haugen Consulting Group, and she has more than 20 years of industry experience. Christy has an extensive background in coding and education and consulting, and she's a national speaker on topics related to ICD-10 and CPT coding, as well as code-based reimbursement. Christy's our lead developer for our coding training materials, from webinars to web-based training to instructor-led training. When Christy isn't developing or delivering training, she also enjoys auditing and helps out with DRG and APC audits. Christy devotes extra time to mentoring current and future coders through her Coder Coach blog, as well as being a proud mom to Sadie. So Christy, I think at this time, I'm ready to turn it over to you and have you kick us off.
All right. Thank you, Kathy, and welcome everybody to today's presentation as we talk about significant procedures. And like many of the webinars that we produce, this one really was born out of our coding audits and some things that we've noticed as we've been auditing on the inpatient side, which procedures are picked up and also the sequencing of those procedures. So what should you be coding and how should you be sequencing those? That is the topic for today's presentation. So we are going to start with, all the boring specifics and taking this all the way back to the Uniform Hospital Discharge Data Set, or UHDDS. And it is the UHDDS that sets up or defines what it is that we need to report and defines what a significant procedure is and a principal procedure and all of that good stuff. I will mention that a few months ago I wrote an article for ICD-10 Monitor, and I do have that referenced at the end of this presentation if you want to go out and take a look. It was about the sequencing of procedures, and again, it's being something that we see regularly on our coding audits. It's something that I think is a pretty big subject. So UHDDS, in case you're not aware of what it is, or in case you've heard of it but you're really not sure where it comes from, it is a minimum data set that was established for hospital inpatient reporting. And what UHDDS says is that they are going to collect a certain set of data elements on every hospital inpatient, and the criteria that they look for in reporting that is it's got to be something that is easily identifiable, readily defined, uniformly recorded, and easily abstracted from the medical record. And any of you who are inpatient coders might be kind of snickering at these last couple, because as we know, there's nothing that is uniformly recorded in a hospital medical record. And it's not always easily abstracted either, especially in this day and age working with electronic medical records. It's not as easy always to pull that information out as the UHDDS makes it sound like it should be. The UHDDS is required by Medicare and Medicaid, and also for many other payers who are out there. As far as where to find the information, there is the UHDDS guidelines are noted throughout the official coding guidelines for ICD-10-CM, and that's probably what we're most familiar with. But they also have a definition for significant procedure, which is not in our PCS coding guidelines, but is noted in an old issue of Coding Clinic, which I will reference here on the next slide. So let's first of all talk about what UHDDS says a definition of a significant procedure is. They say that elements of a significant procedure those are things that are surgical in nature, carry a procedural risk, carry an anesthetic risk, or require specialized training. In addition to that, As I mentioned, Coding Clinic does define significant procedure. It's noted in fourth quarter 1990, and it is also in the American Hospital Association's Coding Handbook for ICD-10, CM, and PCS. So if you're looking for that official reference to it, that is where it is. And it was also published in the Federal Register all the way back in 1985. So I've not tried looking that up. I don't know if it's available online, but we do have good resources through Coding Clinic and AHA where we can access this information. So the Coding Clinic article from 1990, in addition to defining significant procedures, also tells us that all procedures that affect payment determination must be reported. And that would include, you know, any surgical procedure. I think those are the easiest ones to pull out. I think we're all pretty good at pulling out mechanical ventilation because those impact reimbursement. But if you are just getting used to APR DRGs, you might notice that there are some procedures that impact severity of illness and risk of mortality that aren't things that we would typically think to pick up. So it is important to be aware of any of the PCS codes that are going to impact payment. And then Coding Clinic also says that all other procedures may be reported at the facility's discretion. And you know that we've been coding or auditing quite a few charts since ICD-10 went live, and we've seen pretty much everything from, you know, hospitals picking up just the bare minimum procedures, those things that are going to be surgical in nature or impact payment, to facilities who are picking up absolutely everything. And I'm sure in your facility, productivity is always an issue, and the more codes we assign, the more it's going to impact productivity. So you want to be careful. You may want to go in and create a facility policy, which is something that we will address during today's presentation as well. So let's start with those criteria for significant procedure and talk about procedures that are surgical in nature. And that Coding Clinic all the way back in 1990 said that surgery includes incision, excision, amputation, introduction, endoscopy, repair, destruction, suture, and manipulation. And if you bring that forward and apply that into ICD-10 PCS, you'll notice that that includes pretty much everything in the medical and surgical section of PCS, any code that starts with the number 0. And examples of that, some very straightforward examples: appendectomy, mastectomy, colon resection, coronary artery bypass. I mean, I don't think there is a coder out there who would not agree that these are important procedures that must be reported. These are also easy to find in the medical record, hopefully, and you should have a procedure report to go along with these because usually there's some anesthesia involved with them as well. So any procedure that is surgical in nature. There also, the second criterion is procedures that carry a procedural risk. And this one might be a little bit grayer. Some things that we consider to be procedural risks that we might recommend coding depending on your facility policy. A lot of facilities have guidelines that say that they will code any radiology procedure that utilizes contrast material. That includes any coronary or vascular angiography. It might include intraoperative cholangiograms, you know, not necessarily things that are performed just solely in the radiology lab, but some intraoperative procedures potentially as well. Blood transfusions, and I know there's been a lot of conversation about whether or not blood transfusions should be picked up in PCS, particularly because we don't always know if it went into a central or a peripheral vein or what the route of administration was, and that's something we need to know in order to assign the code. So some facilities have chosen to assign codes for blood transfusions and some have not. And that's something that could be put on your facility policy. Mechanical ventilation is something that carries a procedural risk, and it also happens to be something that impacts payment. So that might be something, is definitely something that you want to pick up. And cardiac resuscitation is another procedure that carries a procedural risk that you could or could not code depending on your facility policy. So you can see where we're starting to get into some of the gray areas. Procedures that carry an anesthetic risk. This one I think is also fairly straightforward and kind of pulling some principles from CPT coding, which in the facility CPT realm of things, CMS considers any procedure that includes local, topical, regional, general anesthetic or conscious sedation to be anesthesia. And I would say that for the most part, we probably do code anything that requires anesthesia. And then the last one, the last criterion, which I think is also kind of gray and subjective, is procedures that require specialized training. And some examples of this would be a non-excisional debridement of a wound at bedside, or placement of a PICC line at bedside. And then we kind of get into that whole IV thing. You know, we don't code IVs in the facility. At least I've never seen anybody code IVs. Pretty much everybody who goes into the hospital gets an IV in the case that they need to receive medications or fluids or need to give blood or whatever they need to do. But we do code PICC lines and central venous catheterizations, and mainly because of the procedural risk that is associated with that, because the tip of those catheters are located more closely to the heart than your typical IVs. So this is one where I could argue and say, yeah, putting in an IV requires specialized training, because I certainly can't put in an IV. I'm not qualified to do that. However, it doesn't have quite the same weight of procedural risk that a placement of a central venous catheter PICC line does. One of the things that I want to remind you of is that just because there's a code for it doesn't mean you have to assign it. And this was something, it was kind of a mantra we had when we were doing ICD-10 training a couple years ago. You know, we went from this coding system in ICD-9 that had a couple thousand procedure codes to what at this point in PCS feels like almost an unlimited number of available procedure codes and the ability to grow that. Well, there are codes for all kinds of things, but you know, there's also a lot of words in the dictionary, and just because there's a bunch of words in the dictionary doesn't mean that you use all of them. So I think a lot of times coders will say, oh, well, there is a code for it, but that doesn't necessarily mean that we need to assign it. So there are a couple of considerations that we recommend for code assignment. Well, first of all, does it impact the DRG? And I'm not trying to suggest that we're just coding for dollars here. That's not a game show. But if you are utilizing those resources and your procedure code is something that impacts reimbursement, then absolutely you want to make sure that your facility is getting reimbursed for that. But going beyond reimbursement, remember that this is also about data collection. So is there a state or a national requirement in order for that certain procedure? You may work in California, for example, where they have OSHPD data that they collect, and OSHPD gives a lot of specific guidelines on what needs to be recorded and reported in order to satisfy the state of California reporting requirements. In addition to that, it's not just state and national reporting, but does your facility have a need to collect that data? Now, when I was a coding manager, we kind of didn't advertise that we could pick up certain things in a code record, through the use of codes, because it seemed to me like every week there was somebody sitting in front of me asking to collect data. And every time I would go to the coders, you know, it's impacting productivity a little bit more. So if your facility has a need to collect the data, things you need to be looking at are, is there any other way to get this information? Can I get this information from another department? For example, we have some clients who have determined that they can get their blood transfusion information from the blood bank. So maybe they don't want to report those because they feel that it's too big of a productivity hit. That is something that somebody in your facility who has both coding and data knowledge needs to be able to define. Also, procedures performed at bedside may be coded if they meet the significant procedure definition. And I think that those are sometimes easy to overlook. It might be, you know, it's buried somewhere in a progress note. And if you use computer-assisted coding software, maybe it picks it up and maybe it doesn't. But something to be aware of. So that is going to bring us to our first polling question. Kathy, would you please lead us in our first polling question?
You bet. Thanks, Christy. So everyone, you should see the quick poll on your screen. So the question is, placement of IV codes should be coded since they require specialized training. Is that true or false? So what do you think? Placement of IVs should be coded since they require specialized training. True or false? Anybody else want to weigh in? I've got the majority. I like to always see if I can get 100% during these polls. Let me know. If not, I'm going to close the poll. 3, 2, 1. Christy, we've got 95, so a whopping majority say the answer is false, but we do have a small percentage at 5% that says this answer is true.
Okay, so this one is false. I mean, yes, it's true that it requires significant or requires specialized training, but it also is something that we pretty much do on everybody and doesn't quite require quite the same procedural risk as some of our central venous catheterizations. So I would say this is false. I've never seen a facility that codes IV placements, but if you do, I'd certainly like to talk to you and kind of see what your thought process is on that. All right, thank you, Kathy. So moving on to some documentation requirements, which is kind of our favorite thing to talk about, right? I've actually been working on an audit over the last couple of weeks, and it's been a while since I've been knee deep in an electronic medical record, but always one of the toughest things and most challenging things for us as we work with different clients is trying to find things within their electronic medical record. So the Office of Inspector General, or the OIG, in their compliance program guidance for hospitals, says that the documentation necessary for accurate code assignment should be available to coding staff. And I don't know, some of you might be giggling about this one too, because sometimes it seems like we just can't find what we need to be able to report. I think some of the things that come to mind in electronic medical records with procedure coding are sometimes it's difficult to find information for placement of those PICC lines and those central venous catheterizations. It could be in radiology notes, it could be a nursing note, it could be buried in a progress note. You just don't always know. As far as mechanical ventilations, let me just say that I miss paper records and paper flow sheets because it used to be so much easier to nail down that information than it is now. So there is a specific requirement from the OIG if you're looking for any kind of backing to share with the folks who are setting up your EMRs about making information available for coders. Here, this gives you a little bit of official guidance to refer to. There is one thing here though, they do talk about, making it available to coding staff, but then you also have to realize that anything that you code from has to also be something that could be released if there's an audit or if the insurance company comes back and asks for information. And you may have pieces of your electronic medical record that are not considered part of your legal medical record, which is what would be released in a release of information situation. So if you're looking at a scanned document that came from someplace else, then that may not be submitted to another entity if those records are released, and it could present problems with the coding process. Probably not so much on the procedural side as the diagnosis side, and I'm kind of thinking of paramedic trip reports or records from a different healthcare provider with an HMP that is not part of your facility medical record necessarily. So something to be aware of. Something else to be aware of are AHIMA standards of ethical coding. And this is something that I'm starting to bring up more and more in my webinar presentations. I monitor some chat groups on Facebook that are associated with coding and kind of monitor AHIMA's Engage site, and I see questions posed out there and a lot of times think, you know what, this is addressed in the standards of ethical coding. So if you are not aware of the document, I have listed this as a reference and resource at the end of this presentation. It was updated in December of 2016. So if it's been a couple of years since you've looked at it, I would recommend going out and Googling that and downloading it. So the way that they're set up, they have, I believe it's 11 points and 11 standards, and then underneath each of those standards, they go into a little bit more detail on what coding professionals should and should not do. So under this first standard in the red box, to apply accurate, complete, and consistent coding practices that yield quality data, one of the things that they say is that you should be developing and complying with comprehensive internal coding policies and procedures that are consistent with requirements. And they do state that we should be, as coding professionals, developing internal policies and procedures for coding, so facility coding guidelines, that do not conflict with the requirements that are established in the official coding guidelines. And that would include the UHDDS definitions that we utilize and the definitions of procedure, significant procedure, and also principal procedure. They also, I'm not going to read through each individual one of these, but under this last one, to refuse to participate in, support, or change reported data and or narrative titles, billing data, clinical documentation practices, or any coding related activities intended to skew or misrepresent data and their meaning that do not comply with requirements. Wow, that's a mouthful. What does that really mean? One of the things that they list as a bullet point under this is that you should not be misrepresenting the patient's clinical picture by omitting diagnosis or procedure codes. And it is something that I have seen happen before, where the billing office calls and says, hey, you know what? The patient had these 2 procedures and they don't pay for procedure A. So can you just take procedure A off the claim and we'll submit it with procedure B, and then the insurance company will pay for it. And that is an ethical issue for coders. And what we really should be doing is directing our billing departments to go ahead and send it through, but then appeal that denial, because there's probably some sort of extenuating circumstance in that, makes this something that probably should be covered. So taking codes off of the claim just to get it paid is a misrepresentation of what's going on with that patient. On the additional standards for ethical coding, we've got the last 6 shown on this page, and under this first one where it talks about facilitating, advocating, and collaborating with healthcare professionals in the pursuit of accurate, complete, and reliable coded data in situations that support ethical coding practices. This is really our responsibility as coders and coding managers or coding professionals, that when somebody wants us to report something that goes against coding guidelines, or if we're having trouble getting documentation in order to be able to report procedures that should be reported, it is our responsibility to educate those entities and let them know what it is we need to be doing in order to be compliant with all of the UHDDS coding guidelines. And I think it's kind of interesting. I've never wanted to be a lawyer because I always thought, you know, they've got all those rules and guidelines, and you always hear them going back through old cases to look for a precedent. And then I realized that that's kind of what we do in coding. We've got all these rules and all these coding guidelines, and, you know, we've got these ethics that we need to follow. So a couple of other things to point out on this one. The second to last, or the blue box here that is showing refuse to participate in the development of coding and coding related technology that is not designed in accordance with requirements. And one of the things that it addresses is the use of encoders and computer-assisted coding software, or CAC software. And the bullet point under this says that it is our responsibility to recognize that computer-assisted coding and or encoders are only tools that are not a substitute for the coding professional's judgment. So if any of you are concerned that your job may go away with automation, it's not going to happen. I kind of relate it to, I recently read the book Hidden Figures, which they made a movie about, and it was about the mathematician computers and the people computers who were used before automation and were integral to the early days of the space program. And even though they ended up automating a lot of that, there still were people behind the scenes there working to interpret and verify some of those computerized results. So we definitely have a future as coders because we are the ones who are experts in coding and code reporting. So let me present you with an ethical dilemma. And this is a phone call that I received several years ago from the business office. And it was a pregnant patient at 32 weeks gestation who presented to the hospital after being involved in a motor vehicle accident. And she was admitted for treatment of her injuries. And while she was in-house, she went into labor and delivered a live-born infant. Now, the problem was that our facility happened to be out of her network. And for the patient's insurance said, we'll pay for her traumatic injuries, but we're not going to pay for her delivery. And they wanted us to resubmit the claim and take the delivery code off of the claim. So what do you do? Well, we did refuse to remove the code from the claim, and we told our billing office, you know, once you get the denial, then let's go ahead and file an appeal, because in this situation it happened to be a patient who was injured. And it did not make sense to transfer her somewhere else to deliver her baby when we were already treating her for her injuries due to a motor vehicle accident. So there are other ways around this, and nobody likes to think of, you know, the whole appealing and denials thing, but we should not be removing codes from claims, unless, of course, they weren't documented. So let's move on and talk about some guidelines about procedures, because a lot of times I see procedures coded out separately when they really are integral to other procedures. And this is really interesting. I love training CPT coders to be PCS coders, because a lot of times I hear from a CPT coder say, you can't code these two procedures together because they're bundled. Well, the bundling concept does not apply in PCS. I often say, and if you've heard me speak before, you may have heard me say that ICD-10 is from Mars and CPT is from Venus. The two just don't cross. We can't apply the same concepts to ICD-10 as we do to CPT. But we do have specific coding guidelines in PCS that tell us when we can and cannot code procedures out separately. So first of all, first guideline, B3.1b, covers procedures that are integral to other procedures. And what they say is that components of a procedure specified in the root operation definition are not coded separately, and procedural steps necessary to reach the operative site and close the operative site, including anastomosis of a tubular body part, are also not coded separately. And they give a couple of examples here. First of all, resection of a joint as part of a joint replacement. All you code is a code for joint replacement. You don't code the removal of the femur and the portion of the acetabulum before they put in the prosthetic device. And then laparotomy performed to reach the site of an open liver biopsy is also not coded separately. And that actually, in that situation, is covered as part of the approach character. We also don't code anastomosis separately from a colon resection when the two are done at the same time. You kind of figure that if a patient goes in and we remove a segment of colon, we remove part of this tube that moves food and digests it all the way from the mouth to the anus, doesn't it make sense that we're going to connect the loose ends back together before we sew the patient back up? If you kind of think of it that way, then you realize that obviously this is going to be integral and not something that we would code separate. When it comes to devices, guideline B6.1b addresses what is considered and not considered a device. So sutures, ligatures, radiological markers, and temporary post-op wound drains are considered integral to that procedure and are not coded as devices. Now, there was a very interesting coding clinic article back in first quarter of 2014 where the only procedure that was performed was placement of a fiducial marker. And this was a patient who had lung cancer, and they brought the patient in to place the lung tumor, the marker in the lung tumor, and then discharge the patient home. And then the patient came back on another day, a different episode, where they had their CyberKnife stereotactic radiosurgery to remove that lesion. So in this case, you're kind of thinking, well, they didn't do anything else. So do I code insertion of a device? And the answer is no. You code it as inspection, because placement of those radiological markers is not considered, it is not considered to be a separate procedure in and of itself. Coding multiple procedures, and even with all of the education that I've done and how much time I've spent in ICD-10 and with all the audits that I performed, this is still a guideline that I keep coming back to just to make sure that I am hitting all of the points. This is a 4-part coding guideline that talks about when you would code multiple root operations or multiple procedures. So first of all, guideline B3.2a says, during the same operative episode, multiple procedures are coded if the same root operation is performed on different body parts as defined by distinct values of the body part character. On the left side here, we've given you the example that is printed in the coding guidelines. On the right side with our cute little giraffe here, there was a coding clinic article that was published in third quarter of 2014 that addressed the Whipple procedure. And the Whipple procedure is a pancreaticoduodenectomy, which can involve varying degrees of removal of the pancreas, the stomach, sometimes the stomach pylorus, which has its own body part in ICD-10 PCS. And you'll notice for these two procedures, and my third character is the same, which is B, and that third character is the root operation. So these both are the same root operation, which happens to be excision, but we did an excision of 2 separate body parts during this Whipple pyloric sparing procedure, and therefore we need to assign 2 separate codes. Our next coding guideline about multiple body parts is B3.2b that says that you can code multiple procedures if the same root operation is repeated in multiple body parts, and those body parts are separate and distinct body parts classified to a single ICD-10 PCS body part value. This is one that has caused so much confusion. And it caused confusion with us when we first started learning ICD-10 PCS at the Haugen Group as well. And you know, we thought, oh my gosh, this means that anytime the patient comes in and has 5 polyps removed from the transverse colon that we code 5 times, and that is not true. That is not what this guideline says. What it says is you code 1 procedure for every separate body part that happens to code to the same PCS body part value. The example that they give in the guideline is excision of the sartorius muscle and excision of the gracilis muscle. If you look those up in PCS, they don't have a specific body part. They are 2 different body parts in the body. There's the sartorius and there's the gracilis. And if you look in the body part key, they both are reported to upper leg muscle as the body part. So when you have 2 separate structures that happen to report to the same body part value in PCS, then you code this out separately. Another example on the right here from Coding Clinic second quarter 2017. We have fasciotomy of the 1st, 2nd, 3rd, and 4th metatarsal compartments for treatment of compartment syndrome, followed by release of the medial and central compartments of the foot. So they released 6 separate compartments if you count the first 4 metatarsal compartments as well as the medial and central compartments. Therefore, we assign the same code, release of the right foot muscle, open approach, 6 times. All right, next guideline, B3.2c. During the same operative episode, multiple procedures are coded if multiple root operations with distinct objectives are performed on the same body part. In the example that we gave on the right here is a sentinel node axillary lymph node biopsy, and they sent that biopsy to pathology. Pathology confirmed malignancy following the resection, and then they did resection of the entire lymph node chain. So we know that when we code lymphadenectomy, removal of a lymph node, if we take the entire chain, it codes as resection. If we only take 1 or 2 lymph nodes, it codes as excision. And because this was a biopsy, our excision code ends in X to show that it was a diagnostic procedure. So even though they kind of removed a couple of lymph nodes and then they went on to remove that entire chain, that whole procedure is not included in our resection code. So yes, that includes our definitive treatment to take all of those lymph nodes, but then our biopsy code is coded separately. The final multiple procedure guideline, B3.2d, says that we code multiple procedures if the intended root operation is attempted using one approach, but then is converted to a different approach. And we see this quite a bit with laparoscopic converted to open procedures. So the example that we gave is an attempted robotic-assisted laparoscopic hysterectomy converted to open total hysterectomy. And you'll see that we have resection of the uterus with an open approach. That's our 0 as our principal, or as our first procedure. And then inspection for our second code. And this example was pulled from first quarter Coding Clinic 2015. I should have put that on the slide, but if you want to see a little bit more about this particular procedure. I think I simplified this one too. There were a couple of other codes. They removed tubes and ovaries and some other stuff. But again, that was first quarter 2015. So we've talked about what is a significant procedure. We've talked about coding multiple procedures and what coding procedures that are, or not coding procedures that are integral to others, but we've not talked about principal procedure selection. And this is something that has always been out there. It's always existed. That definition of principal procedure goes back to the creation of the UHDDS guidelines back in 1985. But because we never had procedural coding guidelines until we implemented ICD-10 PCS, I think this is something that's often overlooked. In addition to that, encoders do a lot of sequencing for us, and they typically will pull any procedure that impacts the DRG up into the first position. And while that is usually okay, I would say probably 80% of the time, just kind of a guess there, that we have the encoder sequences it appropriately. But what we have been finding in coding audits is that coders are not looking at sequencing of procedures and are not resequencing when necessary. So I will remind you that page 14 of the PCS coding guidelines has the definition for principal procedure. And this is an overall snapshot that shows the hierarchy for assignment of the principal procedure or the first listed procedure. So the very first procedure should be any definitive treatment related to the principal diagnosis, if you have definitive treatment related to the principal diagnosis. If not, if there were diagnostic procedures related to that principal, then that should be coded first. And then that's followed by definitive treatment related to the secondary diagnosis when no procedure is related to the principal, and then all other procedures after that. So the questions that you need to be asking yourself is, why was this procedure done? Was it done to treat something? That's what they mean by definitive treatment. And secondly, was it related to the principal diagnosis or to a different code on the claim? And if you have a procedure that impacts the DRG that your encoder has pulled to the #1 spot that doesn't meet principal procedure, then make sure you're pulling your principal procedure into the #1 slot. Just make sure that whatever the encoder listed first is in your second spot. The UB will take the top 6 procedure codes, so you're still going to be okay as long as it's in the #2 slot. It's not going to impact your DRG assignment or your payment, but you will be satisfying coding guidelines. So let's dissect each individual one of these. The first part of the coding guideline for principal procedure, and our little giraffe here is just kind of summarizing. We have 2 conditions and both were treated. So in the guideline, it says if you have a procedure performed for definitive treatment of both the principal diagnosis and the secondary diagnosis, you are going to sequence the procedure for definitive treatment that is most closely related to the principal diagnosis as your principal procedure. So you are now having to worry about sequencing your diagnoses, but also comparing your procedures to your diagnosis list and sequencing those accordingly as well. So first sequencing example, we have a patient admitted with acute stroke, started on TPA, and the patient suffered a second stroke while hospitalized and required endotracheal intubation and mechanical ventilation. And while it might be tempting to put your ventilation code first because that's going to be the one that drives your reimbursement, you really should be assigning your TPA code first. And if you're like me, it just feels so uncomfortable that I've got a medical and surgical code in the #3 spot. But really, the procedure that was performed for definitive treatment on this patient was the administration of the TPA for the stroke, which was the principal diagnosis. By the way, and if there's a coding clinic reference on any of these slides, I did pull it from that coding clinic. Second example, we have a patient admitted with severe sepsis. A central venous catheter was placed with a catheter tip in the superior vena cava for administration of antibiotics, and the patient had respiratory decompensation due to sepsis and was vented for 40 hours. Again, the principal diagnosis here is going to be the sepsis, and our procedure that is most closely related to that diagnosis is the placement of the central venous catheter for the antibiotics. By the way, if you're going to, look at each individual character in my code, just know that I made a couple of assumptions on the code lists. It's not so much, you may see all the documentation isn't necessarily on the slide to support that specific code assignment. This presentation is just about sequencing. It's not about the specific code assignment today. And that brings us to our next polling question. Kathy?
Okay, I'm launching the poll. So we've got, which procedure should be listed first? And I think I messed up when I typed this in there. Laparoscopic colostomy or placement of a central venous catheter. So what do you think? Which procedure should be listed first? We've got responses coming in. Excellent. So what do you think? I see you guys are thinking about this one. Anybody else want to weigh in? I've got the majority of you. I'm not quite to that 90% goal in my mind, so anybody else want to weigh in? So on your screen, which procedure should be listed first? Okay, I'm going to close the poll. 3, 2, 1. Christy, we've got 79% says it depends on the principal diagnosis. And we've got 21%, so a minority, but are saying it should be the LAPCO.
It's very tempting to say, yeah, it should be the lap chole because that's a medical and surgical code. But really, the correct answer here is that it depends on the principal diagnosis. What if they developed cholecystitis during that inpatient admission and it was a secondary diagnosis? There may be something that they presented for as that was separate, and that central line may have been related to that. So again, your principal procedure selection will often play off of the principal diagnosis. All right, Kathy, thank you very much. So going into the second part of the significant procedure coding guideline, we have diagnostic and therapeutic procedure that are both related to the principal diagnosis. And we also have a diagnostic and therapeutic procedure that is related to an additional diagnosis. And again, the coding guideline says that we sequence the procedure performed for definitive treatment most related to the principal diagnosis as our principal procedure. So the example that we have for this one, we have a patient who presented for shortness of breath and weakness. Chest x-ray showed a lung mass, and transbronchial lung biopsy revealed cancer of the left lower lung lobe. Open lobectomy was performed with adjacent lymph node biopsy. That pathology returned positive for lymph node invasion, and so they had to remove the entire lymph node chain. So in this case, the reason the patient came in and the principal diagnosis is going to be our lung cancer, and the procedure that is most definitive and most closely related to the lung cancer is the resection of the left lower lung lobe. For the third guideline for significant procedure, I think it's pretty simple when you have a definitive procedure that was related to the principal procedure or principal diagnosis. But what happens when you have a diagnostic procedure related to the principal diagnosis and a therapeutic procedure related to the other diagnosis? I mean, it seems like you want to put that definitive code first. And unfortunately, the coding guideline says no, your definitive code doesn't go first because it's not related to the principal diagnosis. So you're going to sequence your diagnostic procedure as the principal procedure since it is most related to the principal diagnosis and takes precedence. So our sequencing example number 4, the patient came in with severe acute meningitis causing respiratory failure, and a diagnostic lumbar puncture was performed, and the patient was vented for 36 hours. And on this one, this was pulled from coding clinic, so this is assuming that the patient developed the respiratory failure later, and that the principal diagnosis on this case is the acute meningitis, and the lumbar puncture is sequenced prior to the mechanical ventilation. Our sequencing example number 5, we have a patient admitted with severe sepsis with acute respiratory failure, and the patient was placed on a vent for 20 hours. The cause of sepsis was bacterial peritonitis. They did a paracentesis, and that fluid was sent for culture. And on this case, because the underlying cause of this patient's sepsis was noted to be the peritonitis, the tapping of the peritoneal cavity is assigned as your principal procedure, since it is most closely related to the principal diagnosis, and mechanical ventilation gets sequenced secondarily. The final coding guideline for significant procedures, if none of the procedures are related to the principal diagnosis, and you have therapeutic and diagnostic procedures for other diagnoses, then you can't assign a procedure code to go with your principal diagnosis, but then it becomes therapeutic as opposed to diagnostic is the way the hierarchy works. So you're going to sequence your most therapeutic procedure first. And the example that we've given for this is a patient who presented with decompensated chronic systolic heart failure and was treated with Lasix. The patient had a right diabetic foot ulcer, which was debrided by excising muscle tissue. The patient also had a right lower extremity angiogram to evaluate the arteries in the foot. So assuming that there wasn't a central line or anything done specifically for that patient's sorry, I don't know why I was thinking infection on that one. Never mind. So this patient came in with CHF, and now they're being treated for this diabetic foot ulcer. So the imaging to that is a diagnostic procedure, but the excisional debridement is most definitely done for definitive treatment. Therefore, it gets sequenced first. And that one, I think most of us can agree, feels more comfortable. It feels more comfortable to put that 0 code ahead of that B code for the imaging. And that brings us into facility-specific policies. You know, as I've been talking over the last almost hour, I'm sure there are certain things that you're saying, yeah, but I still don't know, should I be coding this procedure or not? Well, we've given you a couple of tips to help you develop a facility-specific coding policy. And I'll tell you that when we audit, when I look at some of these things that don't really fall under significant procedure or that are kind of in that gray area, I always ask for the facility policy. And if your facility policy doesn't say to code it, then I'm not going to recommend to pick it up. But if you don't have a facility coding policy, I think personally it's a productivity hit for your coders. If you are a coder, you might be nodding. If you're a coding manager, you might be wondering why that's true. The amount of time that we spend going back and forth trying to decide whether or not to code something could be alleviated by a simple policy that says, you know what, we don't code these types of procedures. So we do recommend developing a facility policy to define those gray areas. We recommend that you put your policy in writing, because as good and as awesome as coders are, we just can't remember everything. And make sure that that policy is published for all of the coders. Usually that's placed, in this day and age, it's usually placed on a shared drive somewhere so that everybody has remote access. Something else, should you ever invite Haugen in to do an audit or somebody else to do an audit, even if it's your internal auditors, make sure that they have an access to those policies as well. It also assists them with their productivity, and it can cut down on the number of recommendations for coding variances that come up. And finally, we recommend that you review and update the policy annually. There may be something that you created policy back in 2005 before we went live on ICD-10, and you said, yes, we're going to pick up these codes because they impact DRG assignment or they impact APR, and those groupers could have been changed in the last couple of years. CMS in particular has done a lot of regroupings with MSDRGs, and they have removed things that used to impact code assignment or DRG assignment into a different DRG so that they don't impact payment. So make sure that you are updating that annually. Okay, Kathy, third polling question as we come into the home stretch.
Okay, so does your facility have a do code, don't code list? It's always interesting to see what we find when we do these webinars, and we always share this information. So, and I can tell you right away, you guys are quick. We've got people responding and they are all over the board. So I think that's also good to know and share. So we'll have Christy talk about it here in just a second. Anyone else want to weigh in? Does your facility have a do code, don't code list? Okay, I'm going to close poll. 3, 2, 1. Christy, like I mentioned, we have answers all over the place. We've got the majority at 58% is saying, yep, they do have a do code, don't code list. We've got 16% who are saying no, and we've got 26% who are saying they are unsure or they don't know.
All right. So for those of you who said yes, awesome, that's great. The only question I would have for you is, when was it last updated? So if it hasn't been updated or looked at to see if it needs updates since October 1st of last year, then you've got some homework to do. You need to go back and make sure that everything that's on there is still valid under the new coding system the new codes and the new groupings that went into effect on October 1st. If you answered no or I don't know, you also have homework. If you don't have a policy, I highly recommend that you get one, because like I said, productivity, productivity, productivity. That's what every coding manager wants to know, is how do I increase coder productivity? I would say that if you don't have a policy, you've got some quality issues. You've got some coders who are picking things up and other coders who aren't. But I would guess that you also have coders who go back and forth on some of those cases, wondering whether or not they should be coding them. And if you don't know, you need to find out. And if you don't have one, create one. And if you do have one, make sure that it's updated. Okay, thank you, Kathy. Going back, a couple of universal considerations when you're developing this policy. And it doesn't have to be something that's 6,000 pages long and lists out every single code that you are going to code. How about just something that says, yes, we code every radiology procedure that uses contrast? I'm making that up. Some facilities do that. It's not necessarily something you have to do. But universal considerations: is there a data requirement either on the national or the state level? If there is, then you should be picking it up. Does it impact MSD or G assignment? Or APR DRG assignment, including severity of illness and risk of mortality? If you answer yes to any of these, then you should be coding it. And then finally, you really need to look at what the documentation requirements are. Is it something that you can get the documentation for? And if not, then how do you get around that? So for example, I brought up transfusions earlier. Maybe your facility decides you want to code blood transfusions on every patient. The problem is you don't know how they were administered, if they were given central vein or peripheral vein. Maybe you decide you're going to meet with the folks in your transfusion center and they tell you, you know what, probably 90% of the time we give it through a peripheral IV. And then you could develop a coding policy that says, yes, we code these blood transfusions. We know that we don't have the route of administration documented, so always code it as a peripheral vein as your body part. That's an example. I'm not saying that that's what you should do, but that is an example of something you could do. If you decide to do that, that's a facility guideline. You need to put it in writing and you need to make it available to anybody who does your coding or audits. Facility-specific considerations. There are things that maybe you said no to all of those questions on the first slide, but then you need to look at your facility. Is there a facility data requirement? And if so, is the data available from any other source? Is there any way you can get this information without having to assign a code for it? Where's the documentation in the health record? We kind of already talked about that. Is the documentation in the CAC application? Is it something that is going to be pulled into the CAC for the coder and be available for them at the time of coding? We want to look at workflow and make sure that we're making it as easy as possible for coders to pull in this information. Again, it's a productivity issue. And what is the level of difficulty to implement? Do we need documentation improvement? Probably yes. Most of the time the answer is yes. Is coder education needed? Sometimes you need to do coder education, not just to let them know we need to pick this up, but why we need to pick it up and where they're going to find it in the medical record. And then finally, what is the projected productivity impact? Because your C-suite, folks in your C-suite are definitely going to be concerned about that. So an example is a coronary angiogram. Maybe is there a data requirement? There isn't on a national level, and let's just say for state's sake, there isn't one for your state either. Does it impact APR or MSDRG assignment? And the answer on this one happens to be yes, it does. This is a code that's actually going to drive you into a cardiac cath DRG. So does it impact SOI or ROM? And then the documentation requirements. So based off of this, most facilities have a policy that says, yes, we definitely always code coronary angiograms because they impact our DRG assignment. I'm going to skip this last polling question since we are a little bit over time. I will point out the references that I used to pull together today's presentation. Notice the ICD-10-CM and PCS coding handbook from the American Hospital Association is on here. And also if you want to just do a quick Google search, the article that I wrote about principal procedure selection back in April for the ICD-10 monitor. And that is going to complete my presentation for today. I do believe that we are out of time for questions. Is that correct, Kathy?
We are 2 minutes past the hour, but if anyone does want to type in any last minute questions, we will be glad to put an FAQ sheet together. And as I mentioned earlier, we will send that out in the follow-up email. So Christy, thank you for a wonderful presentation, and we want to thank our audience for joining us today. Hopefully you enjoyed today's webinar, and if you did, I have a list on the screen right now of upcoming events and webinars. You can also find all of those on our website. Please take a few minutes and fill out the survey when you close down and let us know what you think. And again, look for the follow-up email within 48 hours. That will have the recording link, all materials, and your CEUs. Thank you very much and have a great afternoon. Bye-bye.